Among ST elevation myocardial infarction patients, 40 to 65% have one or more significant coronary stenoses in addition to their culprit lesions. So we're looking at the impact of multivessel revascularization on health status outcomes in patients with STEMI and multivessel coronary disease. To do that, I'm with the study's author for the November 10th issue of JACC, Dr. John Spertus, MD, MPH, Director of the Health Outcomes Research at St. Luke's Mid-America Heart Institute, and also a professor at the University of Missouri, Kansas City. We've had conflicting results about the benefits of non-culprit PCI, correct?
Oh, yeah.
It's a little confusing. So where do we stand, in your opinion?
Well, so it's a shifting playing field. I mean, you know, historically we thought that treating the additional vessels led to increased risks for the patient, increased death. It did not seem wise, and the clinical understanding was that at the time the patient comes in with a completely occluded coronary artery, open that artery, that's their big problem, and then let them have time to heal, reevaluate. If they continue to have symptoms, if they in any way are not doing great after their blocked artery's been opened, then consider addressing the other stenoses that you see. And that has really been embraced for a long time. There have been new studies questioning that. And in many ways, you know, we've gotten much better at angioplasty over the years. We have better technologies, more skill. We're much faster at opening the culprit artery than we used to be in these historical studies. And so as people have tried to push the envelope and say, look, I've got the patient on the table, all the equipment's in place, I easily opened up this proximal LAD, exactly. I see this really tight proximal circ, why don't I just tackle that at the same time? And the culprit studies and other efforts to try and look at the clinical benefits of doing multivessel angioplasty have come out, and there are considerations. Do you actually do it at the time of the initial primary PCI? Do you stage it during the hospitalization to, in essence, preemptively treat these other blockages before the patient leaves the hospital? And the community's been struggling with what's the right way to go. The guidelines, I know, are being changed.
Until 2013, they had said no.
They said no. They said it was a class 3. There are very few class 3 recommendations. In fact, I even believe that the Choosing Wisely campaign, one of the things nominated by the American College of Cardiology was not doing multivessel angioplasty at the time of treating a STEMI. And now we continue to get new data that causes and forces us to rethink that.
I mean, there are going to be apparently new guidelines from the ACC-AHA that in primary PCI, this will have, I think, a class 2B recommendation. So not 2A, but it's moved away from, a step away from that class 3, don't do it harm.
Well, certainly that seems judicious to me. It's hard when there have now been at least 2 clinical trials suggesting, you know, improvements in major adverse cardiac events over time with doing multivessel revascularization, and our own study, which looks at a new dimension and domain to try and say that this is actually harmful to patients, because the emerging evidence suggests that it actually might be quite beneficial. And that's something that I'm excited to sort of see that dialogue enriched, and we'll learn from that.
Now, you started with a large group of patients in, and I may need oxygen before the end, the translational research investigating underlying disparities in acute myocardial infarction patients' health status, or TRIUMPH study.
Correct.
Then what?
Well, so in TRIUMPH, we enrolled consecutive heart attack patients from 24 different hospitals throughout the United States. And the real goal of that study was to understand patients' recovery after they left the hospital for their MI. So we enrolled STEMI and non-STEMI patients. We followed them for a year with serial health status assessments at 1, 6, and 12 months. And we really wanted to understand their symptoms, their function, and quality of life. For this particular study, we were interested in those patients who did have, as you cited in your introduction, multiple other blocked vessels beyond the culprit when they were treated for a STEMI. So it's a very unique and important subset. It's a very unresolved question. And you know, many of the studies that have been designed and many of the analyses that could be done from the NCDR or other large observational registries can only look at survival. They can only look perhaps at subsequent heart attack rates. But one of the principal advantages of treating another blocked artery is alleviating the patient's angina, improving their quality of life. Those are critical benefits of percutaneous revascularization. They're a real goal for treating our patients. And so we questioned, well, if we compared those who did and did not get multivessel revascularization at the time of their original procedure, was their health status better over the next year? And this was not a randomized trial. It was an observational study. We used a lot of sophisticated statistical methods to try and compare apples to apples, and it will never, sort of be perfect. But what we saw was that patients who had multivessel revascularization had significantly better angina control over the following year. They had significantly better quality of life over the following year than those patients whose other blocked arteries were not addressed. And I hope that this stimulates those who will be designing future clinical trials to think about the patient's perspective and capture their symptoms, their function, and quality of life, because it's a very important additional benefit of offering multivessel revascularization, and one that we can quantify and understand, and eventually recognize that some patients will get even more quality of life benefit from multivessel revascularization, and some may not. And we can take a more conservative approach with the latter, but those who benefit a lot, we should be very aggressive in treating their other blockages.
I probably should ask you, what was your definition of multivessel revascularization?
So it was addressing the, leaving no artery with greater than 70% stenosis. So it's treating the other arteries with that had a 70% blockage or more during the hospital stay.
Now, multivessel revascularization was associated with improvements in both angina and quality of life, but not mortality or repeat revascularization procedures. You quote, to our knowledge, this is the first study to evaluate patients' perception of their systems and quality of life. And at this meeting, you're talking about the case for and arguments against moving quality of life assessment front and center, correct?
Correct.
So what are you talking, in that particular discussion you're having here, you're going to argue with yourself, because in the paper you're obviously saying quality of life can be very important. But is it time to move it up front and center? What are the arguments for? What are the arguments against?
Well, so fundamentally, what are our goals in treating our patients? We either want them to live longer or feel better. And, who would have thought this? But in the setting of acute MI, we've made such improvements in survival, which I think is the most important outcome, that now we can't really detect any differences from a lot of the new innovations on survival. So what do? Well, we combine it with other things. We combine survival with, rehospitalization. We combine survival with bleeding. We combine survival with repeat procedures. A lot of those other events aren't nearly as bad as death. And what we haven't done is say, well, why don't we start paying a lot of attention to capturing how our patients are feeling? If that's one of our goals, is to make them feel better, to have a fuller quality of life, to have fewer symptoms, we ought to be designing our trials for that outcome if we don't have the power within death alone to detect differences, because we can still define ways to treat patients that improve their outcomes. And there's nothing wrong with making patients feel better, even if you don't make them live longer. Given the choice of living a set amount of time with no symptoms and excellent quality of life, or a lot of symptoms and poor quality of life, I would want the former. And so and this is the kind of discussion I have with my mom. She gets this. Why the agency, why the larger scientific clinical cardiovascular community hasn't embraced health status as an equally meaningful goal of therapy and outcome to be quantified front and center in clinical trials baffles me. For 20 years we've been talking about it, and we see studies where the only benefit of the intervention is in quality of life. Courage is a great example. Didn't alter death, didn't alter MI. Significant improvement for a year or two with symptom control and quality of life. And you haven't seen angioplasty completely go away in stable coronary disease because it didn't affect death and MI.
Right.
We've continued to support and embrace it because it improves quality of life. And so if our behavior embraces the value of quantifying and improving patients' quality of life, then our trial design should also emphasize that as well.
Well, for this paper that we have been discussing, please see the November 10th issue of JACC. And for Cardio Source World News, I'm Executive Editor Rick McGuire.